Hello, everyone. Welcome to another episode of Scoliosis Dialogues. This podcast is the only podcast that is dedicated to the field of spine deformity. And I am very excited to host another episode where we're highlighting some of the amazing research that's published in our key journal, which is called Spine Deformity. I would like to introduce our guest author for today, Dr. Kwadwo Yankey. Welcome.
Thank you very much. I'm happy to be on this podcast.
Excellent. So part of us recording this podcast was coordinating time zones because we're in completely different time zones. And so if you can tell our listeners where you are recording from right now, what country?
Okay. I'm recording from Ghana, in West Africa.
Perfect. Ghana and West Africa. And what time is it there now?
It's now 4:50 in the evening.
Okay. On what day?
Today is Friday.
Okay. All right. So it's not so bad. So I'm recording in Dallas, Texas, and it's 11:54 in the morning on Friday. So not so bad as some other countries. But I think, again, this highlights the wonderful international nature of the Scoliosis Research Society, where we have amazing surgeons from all across the world producing great research. And so we will be talking about one of your articles that was published in the most recent journal for spine deformity. However, before we do that, I wanted to just get a bit of background on you, yourself. And so can you tell the listeners where you were born and what your parents did for a living?
Thank you very much. So I was born in Ghana, the western part of Ghana, called Takoradi. My father was a French teacher, and then my mother was a nurse. Yeah.
Okay, so your father was a teacher and your mom was a nurse. So did they, from the very young age, tell you that you could only be a doctor, or did you have other aspirations as you were growing up?
Well, when I was growing up, so over here we do have apartment for nurses or health professionals. So I grew up in a hospital environment. We lived close to the hospital. There were nurses close by. There were doctors close by. So I saw the way health professionals worked, and I used to go to the hospital a lot with my mother. I think I developed the interest to work in the hospital, and as I grew up, I thought I should be a doctor. So that's what, and I stuck to that to dream of being a doctor.
That's excellent. Actually, the very first healthcare professional I ever shadowed was a nurse who worked in the recovery room after people had surgery. And so it was a very interesting perspective as a young kind of high school student, seeing sometimes these surgeons speak very gruffly to the nurses as they drop patients off. And so it was interesting seeing that perspective very early on, and made me appreciate the roles that everyone has as we try to make care better for our patients. So do you have any other siblings, and did they pursue medicine also?
No, I have a junior brother. He did agriculture, so he's an agricultural scientist.
Okay. All right, perfect. So he's the smart one in the family then.
Maybe.
Maybe, I see. Okay. You're not going to give him that much credit. I see. Okay, so I am very much familiar with the process of getting into orthopedic surgery if you're in the United States and Canada. But in Ghana, can you describe for our listeners the years that you have to spend, I guess, in college and then medical school and then a kind of postgraduate training in order to become a orthopedic surgeon in Ghana?
All right. Thank you very much. So the system is a little different from the US. So we do primary school for 6 years. And then from there, Okay,
And primary
let me just
school
say,
would be the American equivalent of high school. Yes?
yes. So let me
Okay.
say the system we have now is a little different from what I went through. So in my training, I did primary school for 6 years. Then we have secondary school for 7 years. Then afterwards, you enter the university. So after secondary school, you go to university and then you study medicine. So medicine is for about 6, 7 years. After medical school, there's a period of internship for a year. And then afterwards, we start residency. So I train as a neurosurgeon. So to do neurosurgery in Ghana, again, it's a little different from what pertains in the US. So there's an initial 3-year period where you do surgery in general. So every bit of surgery, from general surgery, urology, plastic surgery, go across, study everything. And then after the 3 years, you sit an exam. Once you pass, then you can go into your area of specialty. So after the first 3 years, then I went to do neurosurgery for another four years. That's for neurosurgery program. And then when I finished neurosurgery, I stayed around did general neurosurgery at the main teaching hospital in Accra for about 2 years. Then I came to do a fellowship with Professor Ohineba Boakye at Focus Hospital for a year. And that has been my journey so far. I was with him 2016, and I've been at Focus Hospital since then.
That's excellent. And Focus Hospital is one that's well known to many SRS members. But I was just typing up what you just said there. So we got 6 years of high school or primary school, 7
Yes.
years of secondary school, which we call
Yes.
college,
Yes.
6 years of medical school,
Yes.
and then 3 years of, I would call really an internship in all surgery.
Yes.
And then for neurosurgery, that's 4 years of
Yes.
neurosurgery.
Yes.
So does that mean you're about 90 years old right now?
I'm about what?
That was just a joke, but it's very, very, that's a long time, Kwadwo.
Yeah.
My goodness.
Yeah.
Well, but you know, the time I'm sure flies by as you are learning your craft. And so primarily you train as a neurosurgeon, but does your training in neurosurgery teach you how to treat spine deformities, or did you have to do additional training to specifically focus on correcting scoliosis?
Okay. So neurosurgery over here, really most of the spine cases, whether it's degen, trauma, they are actually treated by the neurosurgeons. So until Professor Ohineba Boakye came around, we weren't doing deformity. In actual fact, orthopedic surgeons did rotations with neurosurgery to get to learn about spine. So I did, as far as degenerative disease is concerned, trauma with spine is concerned, that one I learned that during my training as a neurosurgeon. We used to do post-TB kyphosis, but not too much of big deformities. So after my training, I really came to learn deformity correction and at Focus Hospital and Professor Ohineba Boakye. So that's where I really came to learn about deformity surgery. But during the neurosurgery program, not too much, except for minor post-TB kyphotic deformities. Yeah.
Perfect. Excellent. Wow. So that is so interesting just to hear how training is so different in different parts of the world. But we all come to the same point, gaining the skills to take care of children and adults who have scoliosis. And so to that effect, you were first author in a paper published in the Spine Deformity Journal. That paper is titled Medical Complications and Health-Related Quality of Life in Complex Pediatric Spine Deformities Exceeding 100 Degrees or Treated by a 3-column osteotomy. And this is part of the Focus Research Group. Potentially, if you could give us just a quick 1-minute description of how the Focus Research Group started.
Okay, thanks very much. So the Focus Research Group started when Prof. Wachi came to Ghana um, uh, earlier in the early 2000s, or in actual fact, in the late 1990s. So they used to run a clinic, but then do surgeries at the main teaching hospital at Kolebo. But right from the beginning, data was always collected. So started collecting data, taking pictures from the late 1990s, and
Wow.
had a research, always had a research person with him who worked to put all these things together. The hospital itself was built in 2012, and we have an office dedicated to research with research personnel. We always have about 3 people who are in the research unit who put together all the data that we have, and then we work together with the doctors and everybody to write our papers. Yeah, but
Excellent.
research plays a very important part in our work at Focus.
Excellent. And I think for all of those who have heard of the Focus Hospital, it really sets it apart because you all doing very challenging surgeries, but more importantly, you have shown from an objective standpoint your outcomes in a way that really inspires awe in a lot of us who do similar types of surgery. So just to quickly summarize for the listeners, this paper included surgeons that are within the Fox Pediatric Spine Study Group, as well as the Focus Research Group. And you all basically included patients from 17 different hospitals across the world, which is, again, amazing and something that highlights some of the amazing work that SRS members are doing. And you all basically wanted to look at what were the outcomes in patients who had these big curves measuring 100 degrees or greater, both in the coronal plane or the sagittal plane. And you wanted to figure out what were just the clinical outcomes as well as the patient-reported outcomes. And just to point out a couple of interesting things that I saw in your paper is that when it came to underlying diagnoses, you all had about 37% of your patients had idiopathic diagnoses, about 38% had congenital diagnoses, and about 48% of the curves were primary scoliosis, and the rest were a combination of pure kyphosis or kyphoscoliosis. From looking at some of the other surgical criteria, I thought it was very interesting, first off, that 52% of your patients had a thoracoplasty. And I know that this is kind of a hot topic for a lot of surgeons. And actually, I was having an interesting conversation with Dr. Adagwa, who is now a adult spine surgeon in Cincinnati. And he was mentioning the importance of doing thoracoplasties after these big VCR cases, because you may not actually get as much correction as you wanted, but the thoracoplasty sometimes makes at least the outcome look a whole lot better than what it may have actually been. I would just love for you to just focus a little bit of time on what your thoughts are about the usefulness of doing thoracoplasties after you do a VCR.
Okay, thanks very much. So I think the main advantage of thoracoplasties, like you've mentioned, is to make the patient look cosmetically very good. After VCRs, during the course of the review, take down some ribs, but especially for patients who have large capes, severe trunk rotation, you may actually not end up even doing a VCR. You may just do posterior column osteotomies. But then VCR really, really makes a big difference. Taking down a few ribs really makes the patient look really much better. And that helps in addition to whatever corrective maneuvers you've done to bring the rib hump down. So I think it's a very important bit of a corrective and then corrective maneuvers, and then also to help the patient look well. Of course, thoracoplasty is without complications. Sometimes you get and a fusion and the rest, or you breach the pleura, but the long-term effects, patients are much happy with the work you do.
Now, of the 251 patients that you all evaluated who had a minimum of 2 years of follow-up, you only listed about an 11% complication rate, with many of these patients having large VCRs or posterior column osteotomies. How many of these complications were secondary to the thoracoplasty?
Okay, so what we did know, so for those, majority of these complications were actually pulmonary complications. So overall, we had about 34 medical complications in 24 patients, and 29 patients actually. And then 24 out of these 29 patients had pulmonary complications. And out of this number, about 42% of them actually had thoracoplasty. However, when we tried to find out whether it was a significant factor in these pulmonary complications, and we noticed that it wasn't a significant factor as far as pulmonary complications were concerned. So it's a big figure, but it wasn't significant enough. Yeah.
Okay, so we can't specifically blame the thoracoplasties for the complications.
No, that's what the people found out.
Great. And I think probably one of the best take-home messages is that really for kids with very bad curves, there was only 11% complication rate. But when we look at your patient-reported outcomes at final follow-up, interestingly, patients who had a thoracoplasty had a significantly better SRS improvement in their, to restate that, when patients received their SRS patient-reported outcome instrument, and they compared those scores pre-op to post-op, and then they further compared that to patients who had a thoracoplasty and did not have a thoracoplasty, you all found that the apparent subdomain in the SRS score was better for patients who had a thoracoplasty, as well as their overall satisfaction was statistically significantly better for patients who had a thoracoplasty. I would say that the difference in how much better was not drastically significant, but it was statistically significant. So in your recommendation, are you using this data to tell patients or to tell surgeons to just lay on the thoracoplasties, do as many as you want because the patients are going to feel great 2 years later? What would be your overall recommendation to surgeons who are thinking about implementing thoracoplasties in their future VCRs?
Okay, thank you very much. So I mean, our paper found that thoracoplasty, like you rightly mentioned, in the satisfaction and then the appearance domain, they were significantly better. But we tend to, as to whether you do a thoracoplasty or not, really depends on how bad the hump is and how much residual rotation you have after you've done all your correction. So if typically we tend to do thoracoplasty for patients who have significant tract rotation over 15 degrees. If that is present, then probably the patient is likely to need a thoracoplasty. Then, like I rightly mentioned, it is not without risk. But if you take your time and carefully do it, there's a lifelong, it's going to give a lifelong effect to the patient. So if you take your time, you don't breach the pleura, the outcomes are it's very fulfilling for the patient. However, you cannot go on to take too many reps. We typically do up to a maximum of 4 reps, because if you go beyond that, then the risks of breathing or pulmonary complications really are likely to be much higher. Yeah. The patient could develop a fluid chest. So it's not all the reps you take out. Just look at where the apex of the hump is and then take down those reps. I think up to a maximum of 4 reps should be okay. That's
and I know that you can't be very specific, but when you take out a section of the rib, kind of give listeners a guesstimation for how long is a segment of rib that you remove? Is it a centimeter? Is it a couple millimeters?
Usually we take about, so it's at the apex, up to 4 cm. Yeah, 4 cm thereabout. Yes.
Okay,
Just at the apex, yes.
So 4 centimeters at
Yes.
each of the ribs at the apex.
Yes. Yes.
Okay. Well, there you have it. Plastic surgery within doing VCRs from Dr. Kwadwo Yankey, as he's explained to us. Dr. Yankey, thank you so much for your time. Thank you so much for describing your research. Congratulations on having this wonderful paper published in the Spine Deformity Journal. And I think I would just end with just one final question. If you could give our listeners, especially our young surgeons who are just starting out into practice, some advice on how to do a VCR safely, or when to start doing VCRs on your own, or when or how long you should be doing it with a senior surgeon. If you could just give them some of those recommendations so that everyone doesn't think that we should start doing this sort of surgery on day one of our practice.
Okay. Okay, Jaysson, that's an interesting question. All right. I'm sure, I mean, VCR, it's an important part of the skill every spine surgeon needs. I think that you should take your time to understand the procedure well. Read as much as possible about the procedure, all the possible complications, and about all the stages. There's no hurry about trying out something you're not too familiar with. I think for a start, you need to work with senior colleagues, see them practice, see them do the VCR, assist, and then for a start, anytime you are going to start, let them, when you are going to be on your own, you can be the main surgeon, and then they assist you. And then after a while, you become familiar with the procedure. I would say that you should at least work with a senior colleague. Do about, the more you do, the better. But at least you should do maybe 10 or so with a senior colleague, and then you become familiar with the process. And then you can probably start doing VCRs on your own. You start with relatively small curves, and then progressively, as you get better, you can go on to bigger curves. But you should be familiar with all the risks involved, and then whatever steps you need to take to ameliorate those risks.
Excellent. Great advice, Dr. Yankey. Thank you so much for your time.
Thank you very much for having me.
Welcome to our listeners, and thank you for joining us for another episode of Scoliosis Dialogues. I'm John Vorhies from Stanford, and I'm joined today by Alpaslan Senkoylu. And Alp is a spine surgeon practicing in Ankara, Turkey. He did most of his training at Gazi University, where he's currently a professor. And we have invited him here to discuss with us one of his recent publications looking at an animal model using carbon nanotubes to enhance spinal fusion. Thanks for joining us today, Alp.
Yeah, it's my pleasure, John. Thank you.
Great. All right, so we got quite a bit of a time difference. It's early afternoon here in California. And what time is it in Turkey?
It's almost midnight.
All right. Well, thank you for burning the midnight oil for the sake of educating our members.
Thank you.
Okay, so I wanted to just start by introducing you a bit to our listeners. So you're an active member of SRS. You participate in meetings. So tell us a little bit about how you came to be where you are as a professor.
Yeah, thank you. Actually, after accomplishing my fellowship in Hong Kong, clinical fellowship in Hong Kong, I actually did some small short fellowships as well in Japan, in Norway, and also in Spain. So after this one, of course, after being a candidate fellow in SRS, and then I've been active fellow for last almost 10 years, maybe a bit more than 10 years. And I served different committees of the SRS, including Worldwide Conference Committee, Global Outreach Committee, newsletters committee, And I also served as chair of the Awards and Scholarship Committee between 2019 and 20. So I also actually have some different kind of assignments in different kind of societies as well, like Eurospine and Eospine. It's like this. As you mentioned, I'm practicing in Ankara, in Gazi University. I'm mostly doing the deformity surgeries, including especially the early onset together with the adolescent, and sometimes adult as well. So this is actually my short CV.
That's great. And so is your practice entirely spine, or do you do other aspects of orthopedic surgery as well?
Entirely spine.
Entirely spine. And is that typical in Turkey, or is I know in different countries, pediatric spine surgery is done by pediatric orthopedic surgeons, or sometimes it's done entirely by spine surgeons?
This is a bit atypical, actually. In Turkey, we have like, let's say, if we define a spine surgeon who deal with its daily routine, more than 90%, we are probably less than 20 guys. I mean, in terms of the orthopedic side. But many guys, they are doing like traumas or flexible deformities or degeneratives. But as I mentioned, it's not a usual thing for the Turkey.
Got it. Okay, and then maybe just tell us a little bit about your practice now. So you're mostly spine deformity. Do you spend time on, or what percentage of time do you spend on clinical care versus education and research?
I would say it's like 70% clinical and 30% research and education.
All right. Well, that's a pretty impressive breakdown to be able to pull off basic science work like this, as well as doing clinical work. So this is an interesting paper. It's an animal model. Tell us, maybe just give a little Cliff Notes summary for the audience about what you studied and what you found briefly.
Yeah, thank you. Actually, we first of all, this is one of the thesis of my students. One of my students, he's just finished his residency a couple of years back. So during that time, we had collaboration together with our pharmacology, faculty of pharmacology. So this collaboration is a kind of multidisciplinary actually research. So in this actually paper, our aim was to combine a kind of a carbon nanotube together with the biphasic hydroxyapatite and TCP composites, and then we actually just checked and evaluate its success for the posterior spinal fusion in the rat model. And during that time, when we were starting this project, it was one of the first studies that used this kind of actually composite in the spinal fusion model. After that, I saw a couple of more papers, but they actually used different kind of actually composites together with the carbon nanotubes. I just want to, if you like, I just want to explain what is the carbon nanotube
Sure.
For our audience, because it's a bit too much detail for our audience probably. Carbon nanotubes actually like it says a new kind of type of polymer. It contains carbon molecules, and these molecules is a kind of hexagonal shape, and then is a bit different kind of texture. And then this kind of texture actually gives the material property, especially some kind of physical properties, mechanical properties, together with the biological properties, of course. Physical properties are it's very good in terms of the thermal and electrical actually conduct. When I look at its biomechanical properties, its strength and flexibility is very good. And when I look at the biological part, it's because of the surface, it gives facilitates the cell adhesions. So it sounds a very good orthopedic biomaterial. So that's why we actually thought that it's good to use it for the posterior spinal fusion model on the rats.
And you mentioned in your paper, you kind of compared costs of different materials. You talked about, historically the use of ceramics and BMP and nanotubes. Are these expensive to produce? Is this hard to get a hold of, or is it something that's more scalable?
Yeah, very good question. Actually, especially BMP part is very expensive. That's why we don't have BMP group in our paper in study. But when I look at the carbon nanotubes together with the ceramics, is okay. I mean, it's not that expensive. Of course, as I mentioned before, because of its properties, it's during that time we thought that it should be good for a kind of posterior spinal fusion model.
And then, so just to review, so for your paper, you had 4 groups of rats, right? You had it was a posterior lateral fusion model. So you had one where you decorticated and nothing else, another where you decorticated and had the ceramics, another where you decorticated and had the nanotubes, and then one combined ceramic and nanotube group. And then just to summarize your findings, as I understood them, you had essentially no fusion in the nanotube alone, in the decortication alone group. The ceramics, you got some fusion mass, but the combined group, you got overwhelmingly more fusion mass and a stronger fusion. Is that a good summary, you think?
Yeah, exactly. You summarized very well. Actually, we kept our duration of the experiment is at 8 weeks. As you already know that if you let's say wait for 3 months or let's say 6 months, everything is fused in the rat model. So you have a critical time period, which is this 8 weeks. So as you mentioned, in the only decortication or negative experimental group, we didn't observe any kind of actually fusion. But other groups, we actually observed some kind of fusion. We evaluated our experimental groups in 3 actually ways. The first one is the biomechanically. We use the manual biomechanics, which is one of the actually weakness of our study, because our ethical because of the ethical considerations, we need to keep the number of the rats a bit low. So that's why we didn't have a proper biomechanical test, just manual. And the second one is we actually took the micro CT to all of the fusion, and then we actually evaluate with the micro CT the fusion mass. The third one is the histologically we have histomorphometry together with within our experimental groups. It contains like osteopontine. We stain it osteopontine. It's a kind of immune staining. The second one is we have, of course, hematoxin eosine, and the other one is the mesenterichrome. So we just try to observe the collagen production. We try to observe the cartilage formation, especially enchondral ossification, and we actually also observe the matrix production of this new bone formation. So then, as you mentioned, we actually our results showed us that the especially ceramic combined with the carbon nanotube is better than the other groups. But still, if we put nanotubes in this fusion area, it also seems actually acceptable result. And we came into conclusion that our conclusion was the carbon nanotubes really is a good actually or promising material for the posterolateral spinal fusion in rat model.
Very interesting. So one of the questions that I had was about the long-term fate of this substance in the body. So, a lot of the bone graft that I use a lot of allograft mainly in my fusions. And, I like to tell people that it's a normal bone and eventually your body will metabolize it. And then if we were to come back 20 or 30 years from now, we wouldn't really see any traces of it. But that's not really the case with a carbon nanotube, is it? Can we assume that it's going to stay there forever? Are there any potential downsides of that? Do you have any understanding of health and safety data in animal models or people?
Yeah, this is really very good actually comment and very good observation. And we don't know actually long-term effect of the carbon nanotubes. This is the actually most important weakness of this biomaterial. Otherwise, when we look at the short term, it's an inert material. So we don't expect any problem in the short term, but we don't know the long-term in situ effects of this material.
And it's tiny, right? So does it stay there, or is it distributed throughout the body over time? Do you know?
Yeah, this is it stays there actually.
Okay, it's not eaten by macrophages and processed throughout the body somehow.
Yeah, but with the maybe it's in the long term, I don't know, but it can result with a kind of weird debris and together with the, I'm not sure, but it's a kind of stale film actually formation. But as I mentioned, we don't know the long-term effects. But when you look at our study, it's surrounded very well with the host tissue. And actually, our observation, at least for the short term, is promising.
That's great. So can I ask what you use for bone graft in your practice when you're doing spinal fusion?
Especially when I'm doing the actually early onset or adolescent, I'm using the ceramics, the synthetic allografts mixed by the local actually grafts, but not autograft. Actually, it's like just I'm removing the facades and the cortication, and then I just put some ceramics and the synthetic allografts. That's fine. I mean, it's works very well. I mean, for the young individuals.
Mm-hmm. But this might be an interesting option for patients that might be higher risk for non-union in the future.
Yeah, probably.
Great. Okay. Well, thanks for joining us today. Any final comments to close off the podcast?
Actually, it's my pleasure to. This is the first time for me to joining the podcast, and I enjoyed a lot. Hope in the future I will have more podcasts together with you.
Sounds great. We'd love to have you.
Thank you.
All right. So thanks very much for our listeners for joining us for another great episode of Scoliosis Dialogues, and we'll see you for the next one.
Thank you very much. It's my pleasure.
The Scoliosis Research Society is a nonprofit professional organization made up of physicians and allied health personnel. Their primary focus is on providing continuing medical education for healthcare professionals and on funding and supporting research in spinal deformities. Please visit srs.org for further information.